Okay, I think Dr. Nida has covered through the questions, I think, a lot of the common questions which I'll touch on. It can be an interactive case, so feel free to answer the questions that I put forward. It's just to kind of test where everyone is at. I understand that the audience we have today is a mix. I've met surgeons, I've met a bariatric surgeon, there's a nephrologist apparently, internal medicine, family medicine. So with the different backgrounds and different interests, but sharing a similar patient group, I wonder how each one of us would approach such a case. So it's a very simple case. So this is just to test what everyone would do, okay? So we have this lady, Sarah, very typical patient who would come to probably an endocrine consultation or a family medicine consultation, maybe not so much the cardiology clinic or the nephrology clinic, but this would be someone who would present to endocrinology, family medicine, or internal medicine, most likely. So she's, and gynecology as well. So 38-year-old lady with a BMI of 36, so that's class 2 obesity. And her background history includes pre-diabetes and polycystic ovarian syndrome. That's it. She doesn't have anything else, okay? And the purpose of her visit is that she wants to lose weight. She hasn't taken any treatment. She's not on any medications. Very kind of straightforward, common. Can I get a hands up to see who gets these types of patients in their clinic regularly? 2 hands up there, yeah. I mean, they're very, very frequent. I guess dietitians see this as well. So they present, and they're certainly out there. So given her BMI, which was 36, and her history, which seemed simple, but I don't know if I'd use the word simple for someone who obviously has metabolic disease. She has PCOS and prediabetes. That's not simple, okay? In the discussion, she says, I've heard of weight loss medication, I've heard of this and this, and my friend takes tirzepatide. So she asks for it, which is what's happening these days. Actually, the patients are asking us. So we're talking about us initiating, but we're facing a situation now where the expectation from us is to just give it, right? So do you think that it's an appropriate choice in her case? Just a hands up to see who would give her tirzepatide if she asked for it. Yeah, I mean, after some history, obviously, not just a quick transaction, very consumerist relationship. So yeah, I'm here for tirzepatide. Okay, here you go, and we're done, and that's it. That resolves all the issues. So the label indication, I guess it's quite similar for semaglutide as well. So either one of them. So a label indication, we touched on this a little bit earlier. So sorry, this is just changing the slide. So label indication, a BMI more than 30, so she definitely qualifies, even if she did not have the PCOS or the dysglycemia, or being overweight, defined as a BMI more than 27 with at least one comorbidity. Now, again, it's open for debate whether this should be applicable to our ethnicity, where we can have lower BMI with this, okay? And what are those other comorbidities? So any of the metabolic conditions we discussed earlier. So she's, as they define them in the medical world, she's a female of reproductive age. And, I mean, what are you going to tell her about using these drugs? So let's say you agreed, let's assume you agreed on giving her this drug. So again, very important point, because the consultations can be quite lengthy. They're going to talk to you about their lifestyle, their food, their mental health, and the discussions and the treatment of obesity and the history, as Dr. Nida spoke about. You will actually go way back in the history to ask about childhood weight and adolescence weight and family members and food and movement and sleep and other comorbidities that they may have. So in the consultation, sometimes you could actually forget to ask about pregnancy or advise on the risk of what you should think of if there is a possible pregnancy. So she's a woman of reproductive age. She may become pregnant. None of these medications, whether it was tirzepatide or semaglutide, has been studied in pregnant women, and you should instruct the patient specifically. Now, I wanted to highlight this because there is a small difference, a very small difference in the US, the American label for tirzepatide specifically, compared with the EU and the Middle East label. And this small difference in the American label, they are advised to use another form of contraception, such as maybe barrier contraception, during the dose titration period. So when they initiate these medications, even though they may be taking an oral contraceptive, they are also advised to use another form of contraception while they're titrating the drug. There's no evidence that, there is any effect on the absorption of oral contraceptive drugs. However, the US label carries that. In the EU and Middle East, we don't have that. So we do not instruct the patients that you have to use another additional form of contraception in addition to the oral contraceptive that they're on. If this woman planned to get pregnant within the next 6 months, let's say, so when should she stop taking the tirzepatide? So the advice would be anything between 1 to 2 months, so probably 1.5 months. To be on the safe side, probably 2 months is a good time frame before she attempts to conceive. Now, we've had so many unplanned pregnancies occurring, and this is why it's really important that you keep that in mind when you see young women or a woman who may become pregnant. And again, many patients with PCOS may be facing fertility issues, and actually the fertility could be improved once they lose weight. Sure.
Patients who have obesity and insulin resistant and PCOS, they think that they are not going to get pregnant, or they have had problem with pregnancy, and when they start losing weight, suddenly they start ovulating and everything. So those people who thought that they are infertile and maybe not on any contraceptive, or they don't take contraceptive seriously, when they start losing weight, fertility chance changes. So just keep in mind, as you said, that contraception is very important.
Yeah, contraception is important. And actually, the interesting point is some of these women are planning for pregnancy, but yes, they're using contraception. They want to be at a healthier weight before they actually become pregnant. And actually, I find this group, we were having a discussion on why is it that women seem to be losing a little bit more weight in the trials on these medications. I don't know if maybe part of the answer could be those with PCOS who are planning pregnancy or maybe having infertility are motivated during this time frame, because the whole project of weight loss for them is with the intention of improving their health for a successful pregnancy. We have many of these women, unfortunately, they had gone through many IVF cycles as well. So that's really, really important point. Thank you, Dr. Nida.
Tirzepatide or others cancel the effect of oral contraceptives. That's what people are saying.
There are lots of myths, which I guess is why we're addressing this, but yes, a very valid point. So on social media, many things, but I guess it comes from the idea that some people have come up with reduced slow gastric emptying and the oral contraceptive pill not being absorbed. I think that's where they're getting the idea from. We have no evidence that such a thing occurs. And this is why the EU label as well has not mentioned that, because it's negligible. However, in the American label, it's still mentioned that maybe try another kind of contraception as well. But no, and they do become pregnant quite surprisingly fast. And I don't know about you, Dr. Nida, I've had babies named after me. So we've had baby Maryam. Girls, yeah, who got born, which made me very happy because I thought I missed the boat as I didn't specialize in gynecology. But yeah, they do exist, the Ozempic babies, as some people call them. So moving on to her family history, to Sarah's family history. So what if she tells you that her mother had thyroid cancer. Again, I love that Dr. Hani asked this question on social media, because that is typically what happens to us when we're in a consultation with these patients. So they say, doctor, I saw this video that said that, you know, it causes thyroid cancer. So I'm a little bit worried. What do you think? So she says, my mother has thyroid cancer. So what do you think? A family history, Dr. Neda touched on this, but does a family history of thyroid cancer affect a decision to initiate tirzepatide or semaglutide in any patient? Again, as was mentioned, specifically it's medullary thyroid cancer, and the evidence for this comes from rodent studies, not human studies, okay? So it was, and again, we know the thyroid gland in rats are different. They have more C cells compared to humans who have follicular cells. Yes, we do have C cells, but it's specifically for medullary thyroid cancer, which is fortunately quite rare. And again, you have to make sure there is no indication that there's multiple endocrine neoplasia, again, which is fortunately quite a rare condition. But I would say there's no restrictions actually with papillary or follicular, which by far are the most common types of thyroid cancer out there. The trick here is now it's pretty easy for me to say this because I'm actually a thyroidologist, okay? So, and I do my own ultrasounds for my patients and I do the biopsy. So for a thyroidologist to say, no, and you know, it's okay, it's easy for me because that's part of my specialty to diagnose and treat thyroid cancer. But I can really see where the issue is coming with someone who may be not so comfortable with this and, you know, doesn't deal with thyroid cancer. So we'll touch on this later of what to do. So if you're not sure, my advice, I'm just very practical with this. If, let's say you're a family medicine physician or, you know, an internal medicine physician, and they tell you, well, my mom has a history of thyroid cancer, and you don't know what kind of thyroid cancer. Sometimes the patient themselves don't know. So the discussion I have, so I can't even clear them, because they just say thyroid cancer. So how do I know? They don't even know. So I tell them, well, can you try to find out for sure because of this? And if we can't find out and we don't know, maybe we're going to test these people a little bit more, okay? Although it's not advised. But yeah, if I don't know and there is some kind of question that is a gray area, I would want to know, I would want to answer this in a better way rather than just make assumptions. So this paper actually caused a bit of a stir when it was published in Diabetes Care a few years back. So I think it was 2021. And it was a study done in France, kind of a retrospective study from the electronic health records, which looked at what is the risk of thyroid cancer in patients who have used GLP-1 receptor agonists. Now, this was just a retrospective taken from the charts. We don't have and they looked at 3.7 million individuals. And what they suggested was that if there's a cumulative use, so if patients had used GLP-1 agonists consistently for more than 3 years, they were at a slightly higher risk of any type of thyroid cancer, not just medullary thyroid cancer. However, you know, this study does not prove anything, does not show a causative effect. And again, we don't know, thyroid cancer again is common in general, especially papillary and follicular thyroid cancer. So I would say that we needed more information after this, but this study was not any evidence that there is a definite link between thyroid cancer in general, and there's no mechanism to explain that. So we had this study, which was published just last year in the BMJ, which compared the use of DPP-4 inhibitors, GLP-1 receptor agonists in patients over 10 years at least. And there was no increased risk in incidence of thyroid cancer, okay? So so far, the evidence we have, and there have been other studies that have shown this as well, we don't have any evidence that this increases the risk of papillary or follicular thyroid cancer. Now, her mother's had thyroid cancer, so we said, okay, there's no medullary thyroid cancer, no more information. So she says that she was told she has a nodule, which was palpated by her primary care physician. So if a patient has just been diagnosed with a new nodule, which is very, very common, do you proceed with giving, and I think Dr. Nida touched on this, so how would you proceed? I'm interested to know how many of you would actually refer this patient to an endocrinologist. Yeah, so the cardio, I would agree, I probably would as well if I was not working with thyroid patients, I probably would, because it's a new nodule. And, you know, maybe I don't know what to do with the nodules. So I would refer just for, even if they weren't on tirzepatide. But if I was going to put them on a drug, probably even more so. Now, thyroid nodules, why did the FDA, and why is the guidance for people who have nodules and they're about to go, or not people who have nodules, people in general, okay, who want to go on tirzepatide or semaglutide, why are we not advising an ultrasound for everyone? So that's the question. So some doctors ask us, what's the harm? I mean, there's no radiation dose exposure with the ultrasound. It's a cheap test. It's a very quick test. So why not? Why are we not doing it? I mean, they mention that it's an uncertain value, okay, routine monitoring, again, because it's rare. But look at this, I just highlighted this, okay? This is a statement from actually the FDA based on this. May increase the risk of unnecessary procedures. And I want to talk about this a little bit more through this graph. So if any of you are endocrinologists, may be familiar with this, but this was thyroid cancer incidence in South Korea. I actually tell this to all my patients. I summarize, I kind of memorize the study by heart because every single patient who comes to me crying because they were told they have a lump in their neck and it could be cancer and I'm sending you to the endocrinologist. Obviously, I'd be scared if someone told me potentially there's a cancer in my neck, okay? So I tell them about all the history so they understand what they're dealing with, mainly as a consolation. But what happened in South Korea was between 1993 and 2011, they decided they'll do a screening program for thyroid cancer. And what they did a mass ultrasound screening for almost everybody in the country. And what did they find? So you see the blue line there. What is this? So this was the incidence of thyroid cancer diagnosis. So is this a good thing? Now you may think this was such a successful project. We did a screening campaign to look for thyroid cancer and look at how much thyroid cancer we detected that would have not been detected if we didn't do these ultrasounds. Now the catch here is that the majority of these cancers, more than 70% of these cancers were below 1 centimeter in nodules, were below 1 centimeter in size. They biopsied everybody. They did a thyroidectomy for everybody who was diagnosed, even the ones with a small cancer. So what would happen after a thyroidectomy? They ended up on lifelong levothyroxine. They had scars. They lived with the anxiety that I'm a cancer survivor. I survived thyroid cancer. The mental stress and the anxiety that this caused, now, was there a benefit? Why did they stop this mass screening campaign in 2011? That's the question. So why was this between 93 and 2011? It's because they had to show the benefit in terms of morbidity and mortality of their screening campaign. There's no point in screening if you are not reducing advanced disease and you're not reducing mortality, and they weren't doing either. They did not reduce mortality from thyroid cancer through the screening campaign. They did not reduce the advanced cases, but they did so many surgeries which were probably unnecessary, and they created a lot of, anxiety. And if we start scanning everyone's neck now, which is what is probably happening, because we want to put them on a GLP-1, we're technically recreating the South Korean screening program for thyroid cancer. 40% of the population have nodules. And if you're over age 60, 60% of the population have nodules. So you're looking at a huge volume of people who are going to end up having these scans. an unnecessary intervention. Now, gastrointestinal side effects was touched on. So again, these are common presentations in someone who's continuing follow-up with use of these drugs. So after 2 months, she takes the tirzepatide. After 2 months, she says she's nauseated. She's still nauseated from the moment she started it. She's vomiting occasionally and she has some discomfort. So what would you tell her? I think Dr. Nida touched on this as well earlier. So some strategies. So I warn patients when I start them on the drug, because when they know what to expect, it doesn't become such a nasty side effect anymore. So smaller portions, avoid fatty foods, avoid very spicy foods. Don't eat very late at night. Maybe keep 3 hours at least for yourself to digest the food before you go to bed. And drink enough water. Have maybe some caffeine in the morning if you're having constipation as well. Again, studies as well on natural remedies for constipation if it's mild. Kiwi fruit, there's a study actually on 2 kiwi fruits a day which controls constipation, papaya, dragon fruit, apples. So you give them easy, accessible solutions and remedies and ways to mitigate so that they can control these symptoms. If they really needed to, maybe they're going to need an antiemetic, but it's pretty rare for someone to take this all the time. Sorry. And again, you can see this was a comparison of side effects reported on different kinds of GLP-1 agonists. In here, we don't have tirzepatide, but we had semaglutide, dulaglutide, and by far the gastrointestinal symptoms, which we're all aware of, were the most common reported. I really liked these, and I think it would be helpful. I actually don't have anything like this to share with my patients, and I thought it might be a great idea. We do verbalize, and we give them an email and a contact point so that they can report the symptoms. But you can actually maybe give them some of these visual aids. So this was published, eat slowly, all the messages that we gave, but maybe as a visual so that they can remember it. And maybe it can be just a digital copy. So what to do, the habits, the composition, the type of food, the lifestyle that they should exercise as well, what to do if there's nausea. So this looks like advice for pregnant women. So eat crackers. I'm getting flashbacks here. Eat crackers and ginger-based drinks. And then, so again, you see how they're starting with foods that are natural, with things that they have. I don't like the idea of giving someone medication and then telling them you're going to deal with the side effects with more medication. It's pretty harsh to put someone who's just started a new drug on 10 other drugs just for the side effects. And again, to wait and the time frame. So all these visual aids are helpful.
Dr. Maryam,
yes.
Why no straw?
Why?
No straw. Go back. No straw.
Where is that?
Eating habit.
Eating habits.
Second row.
Second row. No straw. Interesting. I haven't. I'm not sure. I haven't looked into the detail of this, of why there's no straw, unless drinking with a straw, eating habit. Maybe it probably because we know people from bariatric surgery at least, and I tell this with GLP-1 agonists, it's similar. Slow gastric emptying. This is, I guess, if you want to lose weight, or maybe, so some people take liquid calories, maybe. I'm assuming this is the reason for it. They take in liquid calories, like milkshakes and stuff like that, and they are able actually to drink a lot, even though they can't eat solid foods a lot.
So overall, if you drink with a straw, you end up with larger ones. I think that's...
Yeah. I think
drinking with a straw, you end up with a larger volume of drinking. And I assume drinking water is, there is no restriction. But if you're drinking anything that has calorie, with a straw, you end up drinking more volume than regular drinking. I think,
yeah.
I don't recommend it.
Yeah, I mean, I remembered now one of my patients, just anecdotally, who had unfortunately 2 bariatric surgeries. So he had a sleeve gastrectomy initially, regained weight, then had a gastric bypass. and regained weight, and then was sent to me to consider medication. And during the consultation with him, I asked him, do you exercise or do you go for walks or anything like that? He said, yes, I can do 5 rounds around Carrefour, which is a hypermarket, a supermarket here. I didn't think, like I was thinking, okay, fair enough, the hypermarket is quite big, you know, so 5 rounds is okay. And then when I asked about diet, he said, you know, I'm having a lot of soft drinks, non-diet soft drinks and crisps and chocolate. And he said, especially the chocolate because it melts and I find it easier. And then I realized how it made sense that his exercise was in the supermarket, just buying the snacks. There's a question, comment, yes?
Basically what happens is when we are sipping in through the straw, we tend to take in the air, right? Which causes disruption in the digestive tract. That is like it can cause bloating.
Okay.
Hi, my name is Deepshikha Agarwal and I'm the nutritionist here.
Okay,
so
great.
For the question of not having it with the straw, the reason is because when you're having it through the straw, there are chances that you take in air, which disrupts during the digestion. So what happens is that air can cause bloating and make you uncomfortable. So that is why when you're having these kind of symptoms, like nausea or vomiting, we tell them not to have it with the straw. That's what we do.
Thank you. So we're learning a lot from our colleagues. I think it's a multidisciplinary meeting and it's really helpful. So the question on pancreatitis. So she takes the tirzepatide and she calls your office. She says she's experiencing upper abdominal pain and tenderness. She doesn't have a fever, tachycardia, or any rebound tenderness when you examine her. What would be your next step? So my concern is always abdominal pain because we're thinking of those potential serious side effects. And I would say, as with any disease, such as diabetes, for example, there's criteria for diagnosis of any condition. And what I'm finding is a lot of people are not looking for the criteria for diagnosis of pancreatitis, and they're throwing around the label based on some lab tests that were done, okay? So the diagnosis, so I went to look at the guidelines for the diagnosis of pancreatitis. So you need abdominal pain, yes, fair enough. Usually it would be described as stabbing abdominal pain in the upper abdomen like a knife going through into your back and you feel it coming through your back. They may have vomiting, they may have jaundice, they may have other symptoms as well. Usually, in any of you who have seen a case of acute pancreatitis, they would be in the emergency room. They would not be calmly speaking to you in your office and you looking at their labs, which were done 2 days ago with a slightly raised lipase and wondering, I wonder if this is. So if it was an acute pancreatitis, you would know because they would be in the emergency. If it's a chronic case, they would still report some chronic on and off abdominal pain. The serum lipase activity, or amylase, has to be at least 3 times greater than the upper limit of normal. Again, there's criteria for the diagnosis. So we shouldn't be throwing around words. I think it's a bit unfair to the patients because they may be unfairly labeled through the electronic health record as having pancreatitis or a history of pancreatitis. And they will not get these drugs in the future, which would have been beneficial for them. So you have to be really careful. And again, same with the thyroid nodules. If it's not your area of expertise, please refer to the specialist who can make this diagnosis and don't just take it all onto yourself. There's a comment, yes?
If there is a history of acute pancreatitis before, you can start the medication or not?
So good question. So next slide is there. The last point I'll just touch on is there has to be imaging findings of the pancreatitis as well. So if you fulfill that criteria, yes. But after imaging results for this lady, she does not meet the full criteria, which is the frequent case in most of our patients. And with supportive care, her abdominal pain subsides. Would you continue tirzepatide in this patient? Probably yes, because she never had a formal diagnosis. Her abdominal pain went away. Now, in the clinical trials, 0.2% of patients treated with tirzepatide had acute pancreatitis. So very, very small number. So I would say it's probably negligible, anecdotally as well in clinical practice. It's not something that we see commonly. However, in the label of the drug, it says if the diagnosis of pancreatitis is confirmed, tirzepatide should not be restarted. So if there was a definite diagnosis of terzepatide, you should not be starting it, okay? And I think that just ends the last case on pancreatitis. Yeah, there was a final diagnosis. I'll just move the... So yeah, when can I stop, I think, is the last thing. So she loses 12 kilograms in 3 months. Would you advise her to stop? We touched on this. If you stop the drug, she will regain, and you can see what happens. This is the same with semaglutide and with terzepatide. So these are the group losing weight. This group stopped the drug, and you can see how they start regaining the weight. Can she switch to another GLP? Again, sometimes for cost issues and for other issues, maybe access. They say, well, I want to stop, but I don't know if I'll find it. I'm traveling to another country. Can I switch to another one? And does she need to start from the baseline dose? The advice is to start from the baseline dose, not to switch. But there has been a study done recently which showed actually there probably is no issue to move to a slightly higher dose on the other drugs. So yes, no problem switching. And this is just a new publication from this year. So in summary, GLP-1, GIP are indicated for treatment of obesity as well without type 2 diabetes. The dose titration should follow protocol. You don't want these gastric side effects. It's contraindicated in pregnancy, in medullary cancer, Men's syndrome, previous history of pancreatitis, again, case-by-case basis, but if it's confirmed, yes. There's a strict criteria for diagnosis of pancreatitis and cholelithiasis as well. So please make sure so you don't label them improperly. And they usually don't have long-lasting effects on weight, so they have to be taken chronically. Thank you.